to another episode of LSVT Global's podcast, Think Big and Loud, where we share inspiring stories, expert insights, and engaging conversations, all designed to empower and uplift the lives of individuals with neurological conditions and those who love and support them. My name is Beth Peterson, and I'll be your host for the show. Today's episode I'm very excited about. It features my colleagues and very special guests, Angela Halpern, who's the Chief Clinical Officer for LSVT LOUD, and Laura Gousset, who's the Chief Clinical Officer for LSVT BIG. And together they bring decades of expertise and experience in both speech therapy and physical therapy, and they'll share their insights into LSVT Loud and LSVT Big. And we're really going to talk about this balance of standardization in the protocols while also being individualized to each patient that we see. So, Angela and Laura, thank you for joining us. I look forward to talking to you about this paradox of LSVT treatments.
Thanks
Thanks
so
for
much for
having us.
having us.
And Laura, I'm going to start with you. If you can just tell us what is this paradox of LSVT loud and LSVT big, and how does it contribute to the effectiveness?
Yeah, sure. I think the word paradox is really interesting. It's kind of puzzling, is it? And you think of LSVT loud and LSVT big, and if you know anything about them, you know that they're standardized treatment protocols. They're very intensive. Patients are seen 4 days a week for 1 hour sessions for 4 weeks, so 16 sessions. And there's a standardized framework and structure of those treatment protocols as well. And so when you think of the standardization, you think, oh, is there any room for flexibility? They seem like opposite ends of the spectrum, but in fact, there is, and that's what we're really excited to talk about today is, the beauty of the standardization is that you've had the ability to study it really precisely for the last several decades, have all of this amazing efficacy research on both LSVT loud and LSVT big, but you also have the ability within the protocols to personalize them, individualize them to each person because every single person is different. And that's what we're really hoping to expand upon today, is to say, like, how do these two things coexist when they seem so different between
Mm-hmm.
standardization and individualization or
Mm-hmm.
personalization?
Mm-hmm. Yeah, well, great. That's a really helpful explanation. We know how important it is to stick to the protocol. And I know we get questions a lot about, well, I don't want to just do this cookie cutter approach. I want to really
Right.
work with my patients. I think that's a perfect way to understand. We do both. So, can you cover some of the common challenges that might occur for clinicians when they're trying to do that standardized dosage and protocol that you're talking about?
Yeah, for sure. I think that when you think about challenges, you think about them both from the side of the clinician and the patient. So on the clinician side, they might have challenges of, well, I don't work 4 days a week. Maybe I in home health or a setting like a hospital setting where we don't see our patients for 4 weeks. Maybe my sessions are shorter than an hour. There's different challenges like that that clinicians experience on their side. And then for patients too, patients may say, oh, do I have to go to an outpatient clinic 4 days a week? I don't know if I have transportation, or it seems really time consuming. Um, what if I really can't get out of the house at all? What if I'm homebound? And so there's a myriad of different challenges to this intensive dosage of the LSVT programs.
Okay, well, thank you. And I know we'll kind of cover a little bit later or as we go through kind of the solutions to those challenges and
Yeah.
how we get through them. And I thought maybe we'd start kind of more in the beginning. Angela, if you can talk about why that intensive dosage and these multiple repetitions and the single focus of loud and big and having homework and carryover, why is that specific protocol so important to the treatment success?
Yes, certainly. So, this, as you mentioned, Beth, there are solutions to these challenges. These challenges are real. Laura and I hear these challenges daily. We've experienced the challenges. but there are solutions. But the reason we don't just say, yeah, it's okay, just do it a couple times a week, is because we have this wealth of research data, 30 years of research that support that the protocol should be done in this certain way. And so we know if it's delivered in this way, it's effective. And so that research support, one of the big reasons that we want to incorporate all these components. Also, the idea of the intensity, the repetition, the saliency, those are based on principles of neuroplasticity. And in the literature, many therapists these days are aware of the importance of neuroplasticity if we want to make long lasting change. The really cool thing about LSVT is we were incorporating these things from the beginning, and we saw the treatment worked. And then, as all this emergent research came out about the importance of neuroplasticity, we were like, oh, well, there's the why. This is why it's working and it's so effective. But what that shows us is we need intensive treatments 4 times a week for 4 weeks, 1 hour session, multiple repetitions within that session if we want to make that long lasting change. And that's the ultimate goal for our patients, is that change that lasts. The idea of the single focus is really beautiful in LSVT. So it makes the treatment really efficient and effective for the patients. So all they have to do is think big, think loud. Now, behind the scenes, the therapists are doing a lot of really elegant, complex things to get the behavior they want, but it's just this singular focus for the patient. And then I think we'll touch on a little bit more later about how that singular focus can also have a spreading across the system. But that singular target also gives us versatility. So while the patient is just thinking loud or just moving, thinking about moving big, we see a spreading of effects across the whole system. So, for speech, we see changes in respiration, intelligibility, articulation. We actually have some imaging studies showing brain changes. And for LSVT big, not just getting that bigger amplitude, but also changes in speed, in posture, in balance. And I'm sure Laura can add some more that I might forget here. But that's the beauty of it. Simple for the patient, but all these other things happen. And then a really important component that makes LSVT different from other treatments is this idea of sensory recalibration. So previously, people would go to therapies and they'd say, I make improvements in the treatment room, but as soon as I walk out, it disappears. And that's because those treatments just focused on the motor system. And while that's essential and important, in Parkinson's, there's a sensory mismatch, meaning that when someone's talking in a quiet voice, it feels normal to them. When they're walking with small steps, that feels normal to them. So if we just say, get louder, think bigger, they can do that, but they're not going to want to carry it over because it feels so funny. So a big part, important part of the treatment is that sensory recalibration so they feel comfortable with it. And so within that, we see home practice and carryover as being these essential components, not only to help maintain that intensity, but to get these behaviors outside of the treatment room so people will use them. So, Laura, I don't know if there's anything I missed from a big standpoint there that you want to add.
No, I think that was a really good broad answer. Mm.
Yeah, well, so with that, so we know that it's very specific, like you're mentioning, and there's a rationale for why all these neuroplasticity principles that have come together. Um, so, how do we ensure that treatment specificity while still remaining flexible for each individual that we see?
Right. So the specificity is very important. And again, with the principles of neuroplasticity, if treatments are going to be effective, you have to treat to the deficit. So in Parkinson's, we have hypokinesia, reduced amplitude of movement. So we're directly targeting that by increasing voice to normal loudness. So increasing amplitude at the level of the voice or increasing movement amplitude, again, just to normal movement, not too big. So that specificity is really important to keep that focus on amplitude, and all the exercises we do in that structured protocol focus on that amplitude in a very specific way, specific set of exercises. So that's where we get the standardization.
Mhm.
The personalization comes in that within each exercise, it's tailored to each individual person. So salience is key. Before treatment, the therapist will find out what are your goals, what are your hobbies, what are your interests, and within all the standard exercises, they're going to tailor it to that. So, for example, with LSVT Loud, one of the standard exercises is reading in your louder voice. But we don't have everyone read the same thing. That's not going to translate to their real world. So recently, we had a client who wanted to be able to give a speech at his son's bar mitzvah. So that was a big part of the practice, was practicing that speech with his therapist so he could deliver it. I had a gentleman I worked with who was a real estate agent. So we also practiced conversation in a loud voice. So we pretended I was the client and he did house showings in his loud voice. A therapist recently just sent this wonderful video for LSVT Big of someone who in LSVT Big, one of the exercises you do is big walking, and he was a clown, so he did parties as a clown. So they actually put the clown shoes on, had him do his big walking with the clown shoes and twirling the baton at the same time. So standard exercise but personalized to him. And also function. So with LSVT Big, maybe someone wants to just be able to get out of bed more easily. So they'll do those standard exercises, but personalized to them. Laura, I don't know, do you have other personal examples of that?
Yeah, yeah, as you were naming those, I was like, man, I can think of thousands of examples. And I think that, people think of LSVT big in particular, and they think of the big exercises, right? But not everyone recognizes that about half of that hour treatment session is spent focusing on tasks that are very, very specific to the individual, whether they're 6 years old or 99 years old. And you think of how you use your body in everyday life, and that is what the therapist really gets to know about you, is like, what do you do during the day that you need to do, that you love to do, and practices those with bigger, better quality movement. And so for a child, it might be things like, interacting with toys or pets or family members, the tasks that they have to do in school, negotiating a classroom environment, up and down stairs, things like that. For a person that's working, it might be, being able to maneuver around at their job site. I remember a patient once that was in a construction job, and he really needed to be able to go up and down ladders, go over uneven terrain, carry things, lift things. Um, it could be being able to stand for 30 minutes and, lead a meeting using your big posture and your big voice. It could be taking care of your family members. We had a client once that his task that he really wanted to do better was to fasten his baby's diapers, because
Mm,
his arm that was more affected by the Parkinson's didn't fasten it as tightly, and the diaper was always, getting loose and, having accidents and leaks and stuff
mm,
like that. Other people, it's very basic skills. Maybe someone has advanced Parkinson's disease or another condition that their mobility or their voice is really limited. But the main things in their life are, hey, can I roll over in bed by myself when I am getting uncomfortable? Can I get up off the toilet with less assistance or by myself? Can I, maneuver to go to the bathroom? Can I reach my utensils and feed myself? So it could be very, very basic things like that. The same thing goes with communication as well. We may be working at very high level things like the ability to multitask and cook a meal while you're talking with the TV in the background, maintaining your louder voice. Or it could be some basic needs like being able to tell caregivers, I need to use the bathroom or I love you, whatever it is for that individual. And so I think as a therapist, we all are very creative people intrinsically, and we all really, really care about people. And I think that's the most fun part of LSVT Loud and LSVT Big is getting to know your clients, being able to creatively think and know who they are and create tasks that are very specific to them. And I think that's also something that really differentiates the programs is they're not just purely motor exercises. You get to practice all those functional skills so that they're walking out the door after 4 weeks of treatment, not just fit, not just, better balance, better mobility, a stronger voice, but actually functioning better in the real world that they live in.
Mhm. Well, with that, I was going to ask, how does it differ, either LSVT Big or LSVT Loud, from more traditional physical or occupational therapy or speech therapy?
Yeah, I'll start first. I lived this experience for years before I was certified myself. And I think there's a number of different ways. And I'll start with PT and OT first because that's my world as a PT. But oftentimes, what we do is approach diseases that are neurological in nature a bit too much like an orthopedic condition, like really heavy on exercises, teaching patients a home exercise program, seeing them for a couple of sessions, working on just core movements, but not working enough on personalized functional skills. So I would say that's one difference. Two is the intensity. Typical traditional physical therapy, occupational therapy for people with Parkinson's is lower in intensity within the session and across sessions. So maybe 1 to 2 times a week is really common, sometimes 3. But I would say on average 2 times a week. And LSVT is 4 times a week, and it really pushes you to treat your patients more intensively, and then you get to see the amazing outcomes that come along with that. Also, in addition to the functional practice that is on top of the motor exercises, really looking at the teaching techniques that are utilized within LSVT is very different. Um, Oftentimes, what happens in a PT session is that you'll instruct your patients in an exercise and then you kind of sit beside them and watch them do it. Or you come back and say, okay, I'll come back in 5 minutes after you've completed this exercise. LSVT is really different because you're actually using your body to show them, to model how to do exercises, and you're doing all the repetitions with them. You're encouraging them, you're coaching them, you're driving them to levels of effort that they probably didn't know they were capable of. You might not know they were capable of. And then really the huge difference is this piece of calibration. Angela mentioned that there's a sensory mismatch. So people don't always recognize that their voices are too soft. They don't recognize that their movements are too small, especially with Parkinson's disease. And this is something I did not realize before I got trained in LSVT myself. And when I started to understand that and see that in my patients and address it, it made a huge world of difference. And I love teaching clinicians about that too when we train LSVT Big because it's just a total game changer when you recognize the sensory deficits and how to recalibrate their brains so that by the end of that 4 weeks, they've had so much repetition of practice. It's been so ingrained in their brain that they're like, okay, yes, this is my new way of moving. This is my new way of speaking. I'm going to do it not only in sessions with you, but I'm going to continue doing it in my daily life because it's so effective. People hear me now. I feel like I'm moving so much better, not always the one lagging behind. So those are some of the key things. But Angela, I think you probably should chime in a little bit more for the LSVT loud side.
Well, it's really parallel. I mean, the intensity, and that was one of the things before LSVT started were unfortunately, people weren't getting referred for speech therapy because the consensus was speech therapy doesn't work. Well, a couple of the reasons it didn't work were it wasn't intensive, it was 1 or 2 times a week, and that sensory piece that Laura, you so brilliantly just described there, wasn't incorporated. People didn't know about it. And I have to agree, Laura, that for me is one of the things I didn't realize, because
Mm,
speech was very motor focused in traditional aspects. And that was a big aha for me. And I know every time I teach a course, I agree, it's an aha for the therapist. And then I never get tired of seeing that aha for my patients and their families.
mm,
Because think about, if, and I'm doing this from a speech standpoint, but I often think about, if I was talking to you right now in this voice, which feels very normal to me, but you guys were saying I can't hear you, that's the same perception that our patients have when they're talking like this, but this feels
mm,
normal to them. And
mhm,
so this idea of, well, why can't people hear me? This feels normal, is a little disconcerting. And so once we explain there's a sensory mismatch, we play their voice back, they hear, oh, I really am quiet. And this is because of the Parkinson's. This isn't something wrong with me. This is because of the Parkinson's. And we work to help them feel more comfortable with the louder voice. It's such a great revelation for them, and aha. And also for the family. So when the families say, why can't they just speak up?
mm,
Explaining the sensory mismatch, or Laura, you probably get, why can't they just move bigger? And that it
mhm,
takes, this is another reason intensity is important, it takes that 4 weeks to not only make the motor changes, but those sensory changes as well. So,
mhm.
yes.
All right, thank you. That was wonderful. It's great to hear those examples, across both LSVT Loud and LSVT Big. So I wanted to come back to, I know in the beginning, Laura talked about some of the challenges that might come up. So Angela, can you talk about how treatment can be adapted to individuals who might have different cognitive abilities or other diagnoses? I know it was focused on Parkinson's in the beginning, and we now use it with other populations. So, can you tell us how it can be adapted to those other situations?
Sure. This is one thing that I think is a very common misperception, is that LSVT loud or LSVT big are only for people at a certain level of Parkinson's disease. And we want to dispel that and say, no, you can do it from people who are newly diagnosed all the way to the end stages. And we do that with making some adaptations. So we don't alter the protocol. We're still doing the same number of exercises, still doing the same protocol, but we adapt within that. So, from a cognitive standpoint, some of the ways that LSVT is actually really great for people who have more cognitive issues is this idea of the repetition. So it keeps it simple for them. That they know what to expect. It's repeated. There's consistent cues. And then Laura mentioned the modeling. So that's a huge part of the therapy. Is the therapist models the behavior they want. They don't explain it. So if
Mm,
someone has cognitive difficulties, that model works brilliantly, because they don't have to listen to lengthy instructions. They just
mm,
follow what the therapist is doing. And then within that, too, we can make different adaptations. So I mentioned before that reading in a loud voice is a very common part of the exercises that we do. It starts simple, gradually gets more complex across the weeks of treatment. I had a gentleman who had significant cognitive deficits, and it made reading difficult for him. It made talking difficult for him. So he was a very religious man, and he had a set of psalms and praises that he used when he went to church. So that's what we focused on. And we just read those over and over and over. So he still got all the motor exercise he needed by the repetition and the practice, but it was something very familiar to him,
mm,
very salient, that he was then go to church and be able to say these. So that's just one example of that. And then that saliency piece to add on to that is if people have issues with cognition, we want to make our treatment even more salient, get it into their real world, because then they have a better relation to that. So, again, from a reading standpoint, if someone's just reading a standardized workbook, that's not going to translate to their everyday life, and they're going to have more issues connecting with that.
Mm,
Now, on the other end of that, if we have people who are newly diagnosed, we can add all kinds of motor and cognitive challenges to keep them at a challenged level. So it's really adaptable across that. For other diagnoses, this has been really fun to see. So, of course, we have the wealth of research over the last 30 years for Parkinson's, randomized controlled trials. We know that works. For some of these other neurodiagnoses, or many times clinicians will tell us about things that there's no research on. So there's either no research or small group or case study research. We teach therapists when they go through the training how to go through a stimulability protocol. So they, as the clinician, can use their clinical expertise in conjunction with the medical team to decide would LSVT loud be appropriate or not. But through clinicians doing this, we've seen some really interesting applications of the treatment. And you may say, well, why would that be if it was developed for Parkinson's? Well, also think about how it incorporates those principles of neuroplasticity and motor learning. And so those principles are applicable to a lot of other neurodiagnoses. With LSVT Loud, we have applications with Parkinson's Plus, with stroke, with head injury, people with MS in remission. We wouldn't do it in exacerbation, just to name a few. And then very exciting, we have applications to pediatrics. So research on children with cerebral palsy and Down syndrome. And Laura, I'll let you touch on some of the other diagnoses that LSVT BIG has been used for.
mhm. Yeah, I would say in the years that clinicians have been providing LSVT big, it's been used on a large range of diagnoses, certainly all the atypical Parkinsonisms, sometimes chronic stroke, and we have some emerging research in that diagnoses as well. Sometimes MS, as you said, not in the acute phase, but in more of the a chronic stable phase. Um, Age-related balance changes, it can be quite good for, and that's just to name a few. There are clinicians now also applying it to select pediatric diagnoses like brain injury, cerebral palsy, Down syndrome, and that's an area that we look forward to for future research growth.
Yeah, so I see applicable across many diagnoses, many stages of cognitive ability. So
Mm.
yeah, it's a I love it. Obviously, great protocol. So I want to get back to what you were talking about before.
Mm.
If therapists are concerned about, I don't normally, work 4 days a week, or
Mm.
I don't normally get to see patients for 1 hour sessions. So how do we
Mm.
apply LSVT big and LSVT loud in different settings that might
Mhm.
not lend themselves so easily to have that intensive dosage be part of their schedule?
Yeah, I'll jump in on that one because Beth, I just read a course eval a couple days ago from a clinician. She said, I've heard about LSVT big for 10 years and from patients, families, physicians, etc. And I never got certified because I thought it was just for outpatient therapists.
Mhm.
And so she took the course and then had the aha moment like, wow, I can apply this in my clinical setting. And I think it's expanded over the years as we've learned more, had more clinical experience. But there's lots of different ways. I'll just name a few, and I think these apply for both LSVT big and LSVT loud. So I'll speak broadly about it. Um, One of the things, let's start with an inpatient setting where patients might not stay for 4 weeks. Angela alluded to something called stimulability testing. It's really testing to see, is this patient going to be a good responder to LSVT? And we can extend that and do a trial period, of a week or so of LSVT treatment while they're in the inpatient setting to get a better, deeper look at how they're responding to this treatment. And then if it's going well, that therapist can work with case manager and help to find an LSVT clinician for the next setting, whether it's home with home health, outpatient, nursing home, that kind of thing. And a lot of clinicians don't know about that,
Mhm.
oh, I can do that. Sometimes they can be in rehab and start the protocol, like do the first week or two, and then find a clinician in their community who can complete the remaining weeks of the protocol as well. And with our database of, we've trained over 70,000 clinicians globally, it's getting easier and easier to find clinicians in the area who can pick up the baton and carry on with the treatment protocol. So that is really for that setting. And the same could be for home health as well. We know that there's insurance challenges with home health, but certainly they can start the protocol, they can do some testing, they can educate, screen, all of that in the home health setting. For an outpatient setting, if there's a reason why maybe the patient can't come in 4 days a week or the therapist has some challenges, there are many settings where a therapist will job share. And so that maybe two people are treating that patient for LSVT big or LSVT loud. With LSVT big specifically, both PT and OT can work together to deliver the protocol. Oftentimes it's 2 days a week PT, 2 days a week OT, and they're working on goals that are specific to that discipline on those 2 days, but the patient is still getting the 4 days a week of treatment. And then they can pair with assistants too who are LSVT big certified. So that can be really helpful. There's even clinicians who split a session and PT does the first 30 minutes working on the maximal daily exercises, and OT does the second 30 minutes working on more of the functional application, the functional tasks. So that's one way. Another way is telehealth, and LSVT Loud has been delivered via telehealth for many years and has published research to demonstrate its efficacy when it's delivered in that medium. LSVT Big really just started in the midst of the pandemic. Clinicians, really were forced into that, but discovered that, hey, this can really work with the right clients. Sometimes it is a couple of sessions a week or one session a week in person and the other sessions a week in telehealth. So that technology affords for a lot of flexibility in treatment delivery. And the last one I'll just mention quickly is mobile practice. And some people aren't familiar with this, but if you think about being treated in home, traditionally it was something called home health under Medicare Part A and being very US centric right now. But those were clients who were typically more advanced in their disease to the point where they were homebound. They weren't able to get to outpatient therapy. But now, more recently in the last decade or so, we've had something called mobile practice where for the convenience of you, the patient will come to the client in their home, but bill them under Medicare Part B or bill them as an outpatient. And so it's really, really a wonderful thing. And there's a large number of practices, growing practices across the country who offer this service either as a side or exclusively. That's really what their service does. Um, and that can really help with patients that have transportation barriers where it's just much easier if the clinician comes to them in their home. So those are some really quickly,
Mhm.
but when clinicians are trained in LSVT, we talk about those more in depth as well.
Mhm. Yeah. Well, thank you. Anda, did you have anything to add to that?
That was a beautiful answer. No.
All right, great. Well, we'll wrap up. I just wanted to have you guys, if you have any final words, or I thought maybe you could talk about how this paradoxical approach really can help enhance the quality of life for those patients that we're seeing.
Sure, I'll start and then Laura, please chime
Mm.
in. I think the beauty of this, the paradox that we've been describing, and with LSVT, is you really get the best of both worlds. And I'd like to say this: the best of both worlds from a clinician standpoint and for the patients.
Mhm. Yeah.
So for a clinician and patient, they have the confidence of a standard protocol that can be replicated globally, that has research to show its effectiveness globally. So you have the confidence behind, why am I delivering this treatment this way? Why am I participating in the treatment this way? Well, there's a wealth of research to support that effectiveness. But then that piece that we've been talking about, that personalization within that standardization, which really taps into, how do I then take this and get it into my real world effectively, which is the secret sauce, right? That's the secret to success of generalization. And our goal as therapists, that's what I want. I want my patients not to need me, that they can use this louder voice in their daily life, which then will improve quality of life for them, as they can regain that sense of communication. And I'll let Laura touch a bit more about this with Big, but I know so many times I've had patients say things like, I've lost my sense of self, I've withdrawn, I'm isolated, I don't talk anymore. And then following therapy, they tell you these stories that just give you goosebumps of how they have regained that communication world, and they're a part of that vibrant community again with friends and family. And there's nothing more rewarding than that,
Mhm.
and to see that change in quality of life. So, yeah, those would be my parting words.
Yeah,
Yeah,
thank you.
I think for mine, I would say you might be surprised. If you're a clinician and you're not LSVT certified, I would say take the plunge, get certified. I can almost guarantee you that you'll be surprised at the flexibility that's built into these standardized treatment protocols. There are many more solutions than you're probably aware of for your treatment setting. And you're going to learn a wealth of things that are applicable to many patients, even your patients that you don't provide LSVT to. For patients, I'll say you might be surprised. I have patients sometimes that come to me and they say, "Well, I'm kind of here because somebody dragged me here. My wife made me come. I've tried therapy in the past for this. It doesn't help, it didn't work." And I'll say, let's give it a try. And usually 1 week in, they're like, wow, this is different. I can already see the gains that I'm making just 1 week in. And so if you're a patient out there, you're thinking, oh man, that sounds like super intensive. Can I do this? Yes, you can. And I almost guarantee you that by the end of the 4 weeks, you won't want to quit, because you get so much positive benefits from it functionally. You have a coach that's with you, your LSVT clinician who's very enthusiastic. And so I would just say, give it a try. And if there's things that you're wondering about, whether you're a clinician or a patient, like, is this really feasible for me?
Mm.
Just email us. Angela and I answer emails and phone calls all the time to help people, whether you're patient or clinician, brainstorm about solutions or potential solutions that might work for you.
Those are excellent parting words. So, thank you both for so eloquently explaining this idea of the paradox. I really appreciate all the examples. I think that really makes everything come to life. I mean, it's one thing to say, yes, it's standardized but flexible, but to really hear the real world examples from both Big and Loud, I think really makes it feel real and like, yes, this is possible, both from the therapist side and the patient side. So thank you for providing all those and for all the great wisdom you gave us. And I'll just end with a few credits to make sure we're giving credit where it's due. So a big thank you again to Angela Halpern and Laura Gousset,
Thank you,
for
Beth.
their time and wisdom today. I really appreciate you being here. And the theme song that you're hearing during the beginning and end of this podcast is called Think Loud for Parkinson's by Kindred Spirit and Leo Sayer. It's a new song and video inspired by LSVT Loud speech treatment, and it was developed to raise awareness for Parkinson's worldwide. It's available for purchase on iTunes and Amazon, with the proceeds being split between a UK charity Cure Parkinson's and the Parkinson's Foundation in the US. And very shortly, they're actually releasing an album with this song on it. So we'll be sure, if you stay tuned to the LSVT Global channels, we'll be sure that you can also access that album. The charity album. I want to thank our production team, CS Design Studios, who helps do all the behind the scenes work to make the podcast possible. And if you're interested in learning more about LSVT Loud speech therapy or LSVT Big physical or occupational therapy, or if you want to locate therapists in your area, visit our website. It's www.lsvtglobal.com, and then click below to subscribe wherever you get your podcast so that you never miss an episode. And we look forward to thinking big and loud with you again soon next time. So thank you all for joining us.
Yeah, yeah, yeah.